This lecture is going to be on the menstrual flow and cycle disorders from our textbook. So I have a bunch of them set up here for you so you can just kind of see the different ones that we're dealing with. So amenorrhea, that is what we call an absent cycle for 6 months or more. And when they talk about amenorrhea, they talk about like a primary amenorrhea and a secondary amenorrhea. So primary amenorrhea means that they have not had a menses, okay? So not a big deal when we're dealing with like a young girl. But when we start getting to these teenage girls who are 15 years of age, 16 years of age, and they still have not had a menstrual cycle, then we may want to start investigating, well, why is that happening? Secondary amenorrhea means that they had a cycle and now they don't. So most common reason for that is actually pregnancy. And then the next reason that we would be concerned would be potential for menopause. So amenorrhea just means an absence of a cycle. So again, it could be primary, it can be secondary, and then we need to, figure out whatever the cause of it is. You have hyperamenorrhea, and this is a menstrual cycle or menstrual flow that lasts longer than 7 days. Hypomenorrhea is basically a decrease in the expected amount. So we're talking about like the size of the flow. Menomenorrhagia, this is where you have an overly long and heavy and irregular menstrual cycle. Menorrhagia means we have greater than 80 mLs per menses, which is a significant amount of blood loss. And then the next two are more of like the cycle, like the days in the cycle. So oligomenorrhea means that they have a cycle that is greater than 35 days. So if you're looking at a standard cycle, most cycles for most women are about 28 days. So oligomenorrhea means greater than 35 days, meaning that their cycle comes around less often. Where polymenorrhea means that they have more frequent than a 21-day interval. So they're actually having menses more frequently. So those are the different types of menstrual flow and cycle disorders that typically are addressed for most females. Diagnostic-wise, there's a lot of diagnostic tests that they will do for an individual who's having a cycle flow or menstrual flow or cycle disorder. So one of the most common ones that you see is something called a pap smear. And again, these are all going to be explained in your reproductive assessment chapters. The pap smear is very good at looking at abnormalities, specifically of the cervix. So if we're looking for, cervical type issues, which, is what we're definitely looking at when we're looking at menstrual disorders, a pap smear would be the way to go about that. If you're concerned about issues within the uterus itself, then we're looking at an endometrial biopsy, okay? So the pap smear is more specific for the cervix, whereas an endometrial biopsy means that we would take take a biopsy from that inner lining of the uterus. We could do some cultures. There's lots of different cultures that you can do in terms of looking for menstrual flow or cycle disorders. We can do exploratory laparoscopy, so they can kind of go in and do an exploratory surgery or exploratory scope to kind of visualize what's going on in there if they can't figure it out through cultures and pap smears. There's also ultrasounds that they can do. They can do ultrasounds over the abdomen, but most commonly when we're dealing with menstrual flow and cycle disorders, they're going to do a transvaginal ultrasound, so where the probe will literally go into the vaginal area and you can see the internal structures that way. There is pregnancy testing. You can do pregnancy testing as urine pregnancy, which will either just give you like a positive or a negative, or you can do blood testing, which again, you can still do a positive or a negative there, but we also have the ability to do quantitative analysis, which gives us like a number with pregnancy to give us an idea of how far along a female actually is. So the quantitative numbers will actually increase exponentially the further along in the pregnancy she is. And that's a very useful number when we're looking at, are we dealing with a potential ectopic pregnancy, or, is the fetus growing at a rate that it's expected to grow at. So these are all diagnostic tests that you could see for the menstrual flow disorders. Therapeutic interventions, depending on what we're looking for, we can do something called a dilatation and curettage, also known as a DNC. And what they do with that is they kind of go in and dilate the cervix, and the curettage part is that they're going to scrape the inner lining of the uterus. Very commonly done after a miscarriage or a spontaneous abortion, for example. Because we certainly don't want any retained products of conception left in there that could leave the mom septic. So dilatation and curettage is a common intervention done there. They can do laser ablation. This is common for women who have, breakthrough bleeding or very long cycles, for example, or very frequent cycles. So laser ablation will kind of go in and help the woman with her bleeding irregularities. And then the most invasive of all these interventions is the hysterectomy, and I'll talk about hysterectomy in a different lecture. But the hysterectomy is where they'll actually remove the uterus itself. And if you remove the uterus itself, no, there won't be any more menstrual flow, but the female also will not be able to bear children after that. So it is the last result for a lot of women because that is absolutely irreversible. So we've got to really make sure we've exhausted all of our options before we go in and do a hysterectomy. Okay, things to kind of remember too. Anytime we're dealing with bleeding disorders, we want to make sure that we measure the menstrual flow. So the way that we do that is we actually measure a perineal pad, like we weigh it, and that gives us a very good indicator of how much blood loss we're dealing with. That's the best way to really determine how much we're dealing with. And then we can select our therapeutic intervention based on how much blood we're actually losing. All right, so now moving on to some other types of disorders. This is called dysmenorrhea, and dysmenorrhea means painful menstruation. For this, diagnostic tests, we will examine hormone levels. So we'll look at their estrogen levels, we'll look at their LH levels, their FSH levels, and really see like where our fluctuations are occurring and seeing if that is the cause of the dysmenorrhea. They can also do laparoscopy. So sometimes the painful menstruation can be related to something called endometriosis, for example. So we may have to go in laparoscopically and visualize what's going on internally. We can biopsy, of course, you can biopsy the uterus, you could biopsy the ovaries, anything that we need to go in and determine what's causing this painful menstruation. And cultures, we want to make sure that we're not dealing with a sexually transmitted infection or some kind of vaginal infection. So we can do a culture and determine what we're dealing with. Intervention-wise, we don't do a whole lot for this. We usually do pain control, so mild NSAIDs, aspirin. If we don't have an overabundance of bleeding, we can go with aspirin, but NSAIDs are probably a better choice because it's got that anti-inflammatory property too. Hormone replacements are common. So a lot of women, when they have painful menstruation, putting them on birth control to manipulate the hormones will a lot of times help with the painful menstruation. We may have to go in and do a DNC. So if we're looking at too much tissue in the uterus, for example, a DNC might help alleviate some of that pain. And again, whatever the cause is, we're going to correct it, okay? But for most women, we just got to figure out whatever the underlying cause is and then address it based on what our findings are. All right, the next thing we're going to talk about in here is the premenstrual syndrome, also known as PMS. So signs and symptoms of PMS, water retention, headache, discomfort, change in affect, so that means like the personality, or change in concentration. Premenstrual syndrome is usually present the week before the start of the menses, and these are very common symptoms that a lot of women will experience that week before the start of menstruation. So intervention-wise, medications, so they actually have over-the-counter medications that are specifically for your premenstrual syndromes, like Midol is a common over-the-counter. Exercise, okay, they actually say that exercise increases endorphins, which actually helps alleviate some of the signs and symptoms of PMS. We want to encourage stress management, so we'll address, how does our female normally cope with stress, and maybe give her some therapeutic interventions on stress management. And then we want to limit certain things that we know that trigger the symptoms of PMS. And some of those are limiting alcohol, caffeine, nicotine, salt, and simple sugars. And ironically, you know, the things that we're supposed to be limiting are actually the things that a lot of women do crave during PMS. But we want to encourage her that we don't want her to give in to those cravings. We want her to actually limit those so that her symptoms actually are a little less problematic for her. All right, the next thing in this chapter is endometriosis, and endometriosis is getting a lot of publicity lately on television. I've seen a lot of commercials on this. You see a lot of people that are actually addressing this disorder. And endometriosis just means that the endometrial tissue, which is normally the inner lining of the uterus, is growing outside of the uterus. So we have tissue growing where it's not supposed to grow. And signs and symptoms of this, there's a lot of pain associated with this. There's a lot of swelling. You'll see women's abdomens swell. It can cause organ damage depending on where these endometrial tissue is growing. It can cause scar tissue and damage. And again, depending on where it is, if we're talking about, you know, the fallopian tubes, or if it's growing on the ovaries, the woman can become infertile from the scar tissue that develops. So endometriosis is a big deal that needs to be addressed so that we don't have long-term complications of it. Intervention-wise, surgical intervention is common, so they'll go in and remove the overgrowth of the tissue. We want to usually put the female on like a low-dose birth control to reduce estrogen levels, so they can do that with medication. Worst case scenario, we may be looking at an oophorectomy where they're actually removing one or both ovaries, because those are the ones that release the hormones. We teach the female relaxation exercises to kind of breathe through the pain, and we can apply heat, like heating pads, to the abdomen or back to kind of aid with some of the discomfort that's often felt. So here are pictures where you can see all of the red spots. Those are common areas of where you can see endometrial tissue grow. So it can go anywhere. You can have it on the abdominal wall. You can have it on the ovaries. You can have it on the outside of the uterus. You can have it in the perineum. You can have it on those fallopian tubes. So like I said, anytime we're dealing with an overgrowth of endometrial tissue, it can be a major problem for the female, causes a lot of discomfort. But of course, we're most concerned about infertility issues when we're dealing with endometriosis. All right, the last thing I'm going to talk about in terms of menstrual disorders and flow disorders is menopause. So before menopause, a lot of women will experience what they call perimenopause, which just kind of gives the female an idea that menopause is coming. So signs and symptoms that you'll see is you'll see an erratic menses. So women who usually have like very set menstrual cycles will complain of erratic menses. So, you know, they're going months without a period, or their period is coming more often than usual. So that erratic menstrual cycle. Women will complain of tissue atrophy. A lot of times we're looking at tissue atrophy in the vaginal area, which can cause a lot of problems pain-wise for them. You will have a lot of women complain of decreased lubrication, which makes sexual intercourse very painful for a lot of women. They will complain of hot flashes. So these hot flashes will come on and it without warning, and it's very, very uncomfortable for the female when she does have these hot flashes. Night sweats. I've seen women perimenopausal who will soak an entire, set of sheets in the bed from the night sweats that they get. And then mental changes, you'll see a change in the affect. So maybe she's got what they call a short trigger. So maybe she can change her mood very, very quickly. Okay, those mental changes are associated with perimenopausal symptoms. Treatment for this, hormone replacement therapy is one of the standard treatments, but it's very controversial. So as we've already said, we know that estrogen is a causative course for breast cancer, but also other cancers like ovarian cancer. So anytime we have a female that is already high risk for a female cancer, we want to be very cautious using hormone replacement therapy. So again, it's a very controversial discussion that the woman has to have with her provider and figure out what the best course of action for her is. Other treatments, we can do some dietary phytoestrogens. As we're getting into menopause, we're looking at an increased need for calcium and vitamin D because we're also worried about osteoporosis that tends to come with menopause. We teach our females to dress in layers for when those hot flashes occur. So it may be the dead of winter, and she may be wearing a tank top with a light cardigan because those hot flashes can be so cumbersome. We want them to dress in layers so that they can deal with the hot flash accordingly. We'll also encourage the female to get a vaginal lubricant to help with sexual intercourse discomfort. And we want her to have a healthy diet because, again, we're going into menopause. It's much more difficult to maintain a healthy weight. Usually there's an increase in fat distribution. So we want our female to be on a healthy diet, especially a heart-healthy diet and a low-fat diet. It's also very important that when we have a female going into menopause, to teach her that she can still be fertile for several months after her last period. So the cessation of the menstrual cycle does not mean that she's not able to still have a child. And that is a big shock to a lot of females when they think they're in menopause and then they have an accidental pregnancy. So make sure that we still teach our females that they still may be fertile for several months even after that last period.